mostly using subcutaneous infusions. Uh, how many of you are performing subcutaneous infusions in your settings? Okay, let's start the session. We know in subcutaneous infusion, we are giving or administering the fluid or medications into the subcutaneous space. We know these are the layers of the skin. First one is dermis layer, and just beneath to that there is a subcutaneous layer, and last muscle layer. And here we are introducing the medicines or fluid into this subcutaneous space. And subcutaneous infusions is otherwise called as hypodermoclysis. The word itself means what it is, because hypodermo means beneath the dermis and clysis means slow infusion. And like that, hypodermoclysis, which can also be called as interstitious infusion or subcutaneous infusion. And the only one thing is here we are introducing or infusing isotonic fluids into the subcutaneous space. And for preventing dehydration or to prevent the or to rehydrate the patient or to prevent mild dehydration. And in we know in medical professional we are using hypertonic solution, hypotonic and isotonic solution, but for subcutaneous infusion we are only preferring isotonic fluids. An example for isotonic fluid is 0.9% NS, that is we are commonly giving. And about the small volume versus large volume, like intravenous fluid administration, we cannot administer large volume in subcutaneous infusions. We can
Ma'am, disturbing.
okay.
Some kind of disturbance are there. It's comes
What's that?
only for me or
Am I audible?
but somewhat of
Some sort of disturbance is there.
Any noise?
yes, ma'am.
I think you can continue.
Is it clear now?
Yes, ma'am.
Okay, that's the fan. Okay, we can continue. We only in subcutaneous infusion we only introduce a small volume to prevent to rehydrate the patient or to prevent mild to moderate dehydration. And the common indications for subcutaneous infusion is it is ideal for preventing dehydration mild to moderate. If the dehydration is severe, in that cases, we will not prefer subcutaneous infusion in that for that patients. We will go for intravenous infusion. If the patient is having mild to moderate dehydration, we can give fluids through subcutaneously. And another common indication is if the patient is having severe dysphagia, swallowing difficulty, or if the patient is confused, they can't able to take anything orally. Mostly in oral head and neck cancers, most of the patients will experience dysphagia, and if there is candidiasis, they can't able to swallow. In some confused cases also, patient can take anything orally, medicines or any fluids. That time we can choose subcutaneous infusion. And I already said we are choosing subcutaneous infusions only for mild to moderate dehydration. So the amount of fluid to be administered is less than 3 liter per day. We can administer maximum of 3 liter over 24 hours for that patients. And in palliative care, it is very important because there are most of our patients are suffering from dysphagia and all. So the main common indications of subcutaneous infusion in palliative care is if the patient is having nausea and vomiting. We know in palliative care, more than 50% of patients are suffering from cancer, and they are on opioids for pain management and all. And in between, they will receive chemotherapy and radiation at a regular interval. After chemo and radiation, there is a chance of developing nausea and vomiting. And that time the patient can't, due to that severe nausea and vomiting, they can't take anything orally. If for pain, they can't able to take opioids and all. So we can choose the subcutaneous infusion site for their medication administration. Um, then in mouth, head and neck cancer, if there is any lesions in the mouth, throat and esophageal lesions, they will suffer from uh, severe dysphagia. That situation also we can give subcutaneous infusion. And in intestinal obstruction, we know if the patient is having intestinal obstruction, there is a chance of projectile vomiting and all. So they can't take anything orally. So we can give administer subcutaneously. And if the patient is unconscious, in unconscious patients, we know there is no gag reflex. So if we are trying to give anything orally, there is a chance of aspiration. To prevent this, we can give, instead of putting a Ryle's tube and all, we can give the fluids via subcutaneously. And next is about the intractable symptoms. What do you mean by intractable symptoms? Any idea? What do you mean by intractable symptoms? Any of you? What do you mean by intractable symptoms? Okay, let's see. The intractable symptoms are very difficult or impossible to manage, control, or cure despite appropriate treatment. And they often persist for a long period and can significantly affect a person's quality of life. For example, if the patient is having intractable pain, that means if the patient is having severe pain and we tried oral opioids and all, but it is not, that pain is not responding to the usual pain medications. That is intractable pain. And for some patients, there is some the patient may experience severe vomiting, and we if we cannot able to control or improve the vomiting with antiemetics, that is intractable vomiting. That is the example of intractable symptoms. The symptoms which we cannot able to control through oral or usual treatment modalities. So in that time, we can give it as subcutaneously. Then rectal route is inappropriate. In nausea and vomiting, I already explained, most of our patients in palliative care are diagnosed with cancer. And in cancer patients, we know if the patient is one patient is started with opioids, and after few days, the patient received chemotherapy or radiation, and suddenly he developed nausea and vomiting. And if the patient is in home care, usually how we are managing is, we will instruct the caregiver to make the oral morphine tablet to paste form, and we will instruct them to apply in the rectal area. It is same as the oral absorption. That time, if the patient is can't able to take orally, we can give morphine per rectally. But at the same time, if the patient is having any spurious diarrhea or like any diarrheal symptoms, we cannot give the morphine rectally also. Patient is also experience vomiting, so we choose rectal route. That is also inappropriate for that patient because of that spurious diarrhea. In that situation, we can move to the subcutaneous infusion instead of choosing intravenous. So that is the common indications in palliative care. Is there any doubt in these slides? I think the common indications in palliative care is clear, because if the patient is having nausea or vomiting, next we will move to the alternate route. That is, if the patient is an opioid, we can give morphine per rectally. If it is not, if it is inappropriate, then we can move to the subcu. And oral cancers, throat and esophageal lesion, in intestinal obstruction, and if the patient is unconscious, in that situations we can give subcu. And what are the common subcutaneous injection sites? We know the common subcu medicines we are using is insulin. Like that, we can give subcutaneous infusions or injections to the all insulin sites. They are mainly we are administering subcutaneous infusions to the upper chest. That is intercostal plane. We can give upper arm outer aspect, then abdomen, outer thigh, upper back, and scapular area. These are the common sites for giving subcutaneous infusion or injections. Upper chest, upper arm, abdomen, outer thigh, upper back, and scapular area. And which are the sites? Those are contraindicated for subcutaneous infusion. We know if the patient is diagnosed with CA breast, there is a chance of developing lymphedema on upper extremities, and in some ovarian cancers we can see lower limb lymphedema also. So we know in lymphedema cases we are not allowing needle prick and all. So like that, here also we are not administering subcutaneous infusions or injection to the lymphadematous areas, and skin site that are recently irradiated. Then bony prominence we are not choosing for subcutaneous infusion, and the site is in close proximity to a joint, it is not preferred. Then skin folds we are not choosing for subcutaneous infusion, and if there is any inflammation or infection in that subcutaneous site, that will not recommended for subcutaneous injections. And we also said we can give abdomen also. We are already taking insulin in the abdomen. So if the patient is experiencing any ascites or pitting edema, mainly in ascites, we are not choosing the abdomen for subcutaneous injections or infusion. And if the area is having any tumor scarring, that will not allow. And these are the main contraindication. When we are choosing a area for subcutaneous infusion, we should assess for these points. Is there any lymphedema is there? Is it any recent irradiated skin, or is it to the body prominence, or there is any joint skin folds? Is there any inflammation or infection in that area? These are the main things we should watch before starting a subcutaneous infusion. And the medications. We can give so many medications subcutaneously, but in palliative care, the important medicines what we are giving through subcutaneous is, these are some of the common medications that we are using in palliative care for symptom management. That is, for pain management, we are using morphine. Then haloperidol we are using for delirium, vomiting and all. Then midazolam we are giving. Metoclopramide we can give subcutaneously. Hyoscine butyl bromide we can give. And also injection fentanyl. Like this, we can give some lots of medicines subcutaneously in palliative care. But we are not giving some medications like chlorpromazine, then diazepam we are not giving. We know usually we will not give injection Pandope subcutaneously, and we are not we are not give antibiotics through subcutaneously. But we can give morphine, halo, midazolam, metoclopramide, hyoscine butyl bromide, fentanyl like medicines through subcutaneous. These are some of the medicines that we are commonly used in palliative care for symptom management. That's why I list down these medicines. And some of the common medication we are not using subcutaneous routes. We are not giving antibiotics, and oily preparations we are not giving. I already said we are choosing isotonic solutions mainly for subcutaneous infusions. Then next is about the procedure. Before going to procedure, like intravenous IV insertion, it is same as that of intravenous, and we should explain the procedure to the patient. That is the first step. And I am briefly explaining how it is going to happen, what is happening after giving a subcutaneous infusion. And the subcu infusion fluid absorption mechanism is based on the movement of fluid from the subcu to the bloodstream. We are introducing the medication or fluid into the subcutaneous space. From there, it is absorbed to the bloodstream. And it is mainly causing by three mechanisms, that is diffusion, osmosis, and capillary filtration. And at the first step, the fluid deposition may cause. Here we are introducing the fluid to the subcutaneous space, and that space act like a temporary reservoir. when we are inserting a fluid into the subcutaneous space, that space act like a temporary reservoir. From there, the infused solution spreads between the tissue cells. First, it acts like a reservoir and it will spread between the interstitial space. Tissue cells means interstitial space. From that interstitial space, mainly through three ways it is absorbed to the bloodstream. First is capillary absorption. That is, the fluid moves into the nearby capillaries due to hydrostatic pressure. There is a liquid pressure. So due to that liquid pressure, from that point, the fluid moves from nearby capillaries. From there, they will absorb into the bloodstream. And in this, some larger molecules like some medications and excess fluids enters to the lymphatic system. And from there, they directly go to the bloodstream, and the remaining will happen to the osmosis. And we know there is a different solute concentration. Then there is water, then the water will shift to the balanced concentration across the cell membrane. So this is the mechanism when we are infusing a fluid to the subcutaneous space. First, it will act like a reservoir. From there, the infused solution will spread through the interstitial space. From there, some of them are moving to the capillaries due to hydrostatic pressure, and then there to bloodstream. And some larger molecules will and excess fluids will enters to the lymphatic vessel, then drain to the bloodstream, and the remaining will be absorbed to the osmosis. This is the mechanism of action. And so we should explain the procedure to the patient. Then before starting procedure, we should inform them why we are choosing subcutaneous subcu infusion for you. What is the main indication? What are the complications that we are expecting from this procedure, that you should inform before starting the procedure. Then wash hands. Then we should assemble fluid and tubings, and we should prime line with the selected fluid. Usually for we are giving 0.9% NS as subcutaneous infusion. Instead of this, we can give in palliative sedations we can give if the patient is having severe vomiting and all pain. We can give morphine, perinom, metoclopramide, haloperidol. That all we can give subcutaneously. And before explaining remaining points, next is a video on this procedure. Let's go and see the video and come back.
Subcutaneous infusion of fluids or hypodermoclysis. Mr. Mahesh has advanced cancer of pancreas. Mrs. Lakshmi is his wife and caregiver.
Good morning, Mahesh.
Good morning.
I'm Nurse Arjun. How are you feeling today?
I'm feeling very tired.
He is not eating anything, brother.
Doctor has advised to give on subcutaneous fluid.
Okay.
Requirements for the procedure: a tray containing one sterile tray with lid, sterile cotton swabs, one intravenous solution, normal saline 500 ml, one IV set, one SV set number 23, one pair of clean gloves, antiseptic solution, adhesive tape, one small Macintosh, one kidney tray. Check IV solution. Check the infusion container for sediments, turbidity, change in color and expiry date. Wash hands with soap and water and wear clean gloves. Remove the outer packing of IV solution container. Remove the protective cap at the entry point. Then remove the outer cover from IV set and remove the protective cover at the entry point. Spike the solution container with the IV set without touching the entry point. partially fill the drip chamber by squeezing it till half. Remove the needle of IV set. Then release the roller clamp and allow the fluid to move through the tubings until all air bubbles have disappeared. Close the roller clamp and recap the needle and hang the IV solution. Open the scalp vein set and connect it to IV set. Allow fluid to move through the tubing to the tip of the needle. Disconnect the scalp vein set from the IV set and keep it in the tray. Provide a comfortable position and select the side, which are anterior aspect of upper arms, anterior chest wall, anterior abdominal wall, anterior aspect of thighs and scapular area. Place a small Macintosh under the arm. Cleanse the entry site with an antiseptic solution. Use a circular motion to move from the center to outward and leave it to dry. Take the scalp vein set and hold the needle by the wings. Remove the straight cap of the needle. Ensure the bevel of the needle is facing upwards. Pinch the skin with the non-dominant hand and insert the needle at 30 to 45 degree angle into the subcutaneous tissue. Release the pinch and support the needle against the skin with the non-dominant hand. Secure the needle to the skin with adhesive tape. Date and time should be mentioned on the tape. Remove the needle from the IV set and connect to the SV set using an aseptic technique. Release the roller clamp on the tubing and titrate the infusion to the prescribed rate. Infusion rate should be 1 ml per minute, that is 20 drops per minute. Bring back all the used equipments and dispose as per protocol. Ensure patient is comfortable. Document the procedure including the date, time, site, scalp vein set size and the patient's response. This finishes the procedure for subcutaneous infusion of fluids. Points to remember: maintain aseptic technique during the procedure. Check the site of infusion for signs of infection like pain or redness. If there are any such signs, the infusion site needs to be changed. If there is no signs of infection, the site of infusion can be used for up to 7 days. Normal saline is the most suitable IV solution. 500 ml to 1500 ml of fluid can be administered over 24 hours at one site. The quantity of fluid to be given depends on the needs, the general condition of the patient, and the stage of the disease. The mild edema in and around the site of infusion is normal. Subcutaneous infusion can be safely given in home care settings also. The caregiver needs to be trained in handling the infusion after it gets over.
I think the procedure is clear right now. This is the procedure for infusing subcutaneous infusions. The procedure is same as for injections also. If we need to give sedation and all, we can connect the syringe pump or driver subcutaneously for that. And the main points we should keep in mind is we should explain the procedure to the patient why we are choosing subcutaneous site for medicine administration or infusion. And before inserting the subcutaneous line, we should prime the line with selected fluid. And throughout the procedure, we should maintain a aseptic technique during insertion and all. Otherwise, it will cause infection or inflammation to that area. And we should insert the needle at 30 to 45-degree angle. Usually we are giving subcu injections in these angles. So like that, we are introducing the scalp vein. Mainly we are using scalp veins for subcutaneous infusions. In some settings, they are using cannulas also, but subcutaneous, when we are giving medicine subcutaneously, I think scalp veins are more appropriate because the pain is less in scalp veins. And adjust the fluid drip as prescribed. Next, we are discussing about that volume and rate. And the main points you should remember is we can able to give 1 ml per minute. Maximum we can give 20 drops per minute. If we are giving fluid or medicines, anything, the rate, volume and rate is this, we can only give 20 drops per minute. If we are giving more than 20 drops in a minute, the patient may experience severe pain, or here we are introducing the medicine to the subcutaneous space, and there is a chance of leaking if there is an overload. So please keep in mind, we are only giving 20 drops per minute. And we know we are giving it for mild to moderate dehydration. If the patient need maximum of 1.5 liter over 24 hours, one site is enough for that. That is, we can give a maximum of 1 liter for over 24 hours in a single site. If the patient needs more than 1.5 liter, we should choose another site. In that, we can give maximum of 3 liter over 24 hours. This is the maximum. If we want to give more than 1.5 liter over 24 hours, we should select another site, and maximum we can give 3 liter over 24 hours in 2 sites. And postoperative procedure include, we already said we cannot able to give more than 20 drops in a minute. So do not set up drip rate to deliver more than 1 liter in 2 hours. It will cause severe pain, irritation, and leakage from that subcutaneous site. And document infusion fluid on medication chart. And here we are maintaining a medication chart for these infusions. In that, we will record the name of the infusion, what are the medicines we are giving in subcutaneously, at what time we started, which solution is used for prime the line. Like that, we are using a chart. And check the patient and infusion after 1 hour to ensure that the patient's infusion site is correct. If the infusion site is not correct, the patient may experience pain and edema. And there are no signs of edema, and please check for any edema or leakage. If necessary, the infusion site can be massaged to enhance edema absorption. If there is mild edema and there is no pain, then we can give mild massaging on that area, and that will enhance the absorption of fluid. This is the post procedure. And the main advantages of subcutaneous infusion is it is low cost. We know one IV cannula is cost around 150 plus, but in scalp vein it is cost less than 50 rupees. So it is very low cost and more comfortable than IV administration. We know most of our patients are after receiving chemo and radiation. It is very difficult to get a patent IV line. In that situations, it is more comfortable for the patient and for the family members to administer subcutaneous infusion. And it is less likely than IV administration to cause pulmonary edema or fluid overload. I already said we can only give 3 liter for maximum for 24 hours in 2 sites. So the chance of pulmonary edema or fluid overload is less comparing to the intravenous administration. So it is very safe to use. Then simple insertion, less distressing than IV, easy reinsertion at the new settings. If the caregiver is trained on subcutaneous site injection insertion, it is very easy to take care at home also. And it needs less supervision because trained persons are only doing intravenous infusions, and cannula insertion and all. But if the caregiver is trained in this, there is less supervision is needed for subcu insertion in home care settings. And it does not cause thrombophlebitis because we are not inserting anything into the IV intravenously. So the chance of developing thrombophlebitis is less and has not been shown to cause septicemia or systemic infection because we are not inserting anything into the bloodstream directly. We are giving it subcutaneously. And we can start and stop it at any time and no danger of clot formation. So because there is no backflow of blood or in this subcutaneous infusion. So we can stop or start it at any time. And these are the main advantages because it is very low cost. We are not inserting anything into the anything in bloodstream or intravenous directly. So the chance of fluid overload and pulmonary edema is less, and it is less distressing, and the less staff supervision is needed in home care settings, and chance of thrombophlebitis is less. And there is no chance of clot formation. These are the main advantages of subcutaneous injections or infusions. And there are some disadvantages also. And some patient may experience irritation and inflammation at the infusion site. So before starting subcutaneous infusion, we should assess the site for any lymphedema, any skin irradiation, any wound, tumor, like we should assess, and possible leakage of subcutaneous site. If we are keeping the subcutaneous site we are not maintaining it properly or keep it for a long time, there is a chance of leakage. Then we are introducing more than 20 drops per minute, there is chance of leakage. And rarely some patients show allergic reactions. It is very rare. These are the common disadvantages. And there are some side effects and complications for subcutaneous infusion. So before starting the procedure or introducing a subcutaneous infusion to the patient, we should explain these points to the caregiver or to the patient. There is a chance of localized edema because we are giving injection subcutaneously, and the subcutaneous space is acting like as a reservoir. So there is a chance of localized edema. The edema around the site of insertion of the subcutaneous infusion site we can see, and it will usually resolve by gentle massaging. So if before inserting, you should explain this step to the patient. If you are experiencing or noticing any localized edema on that insertion site area, just give a gentle massage. It will enhance the reabsorption of fluid and the edema will resolve. Then next is about the inflammation or cellulitis. It is a potential complication of subcutaneous infusion. If we are not inserting in a proper way, mainly the inflammation and cellulitis is associated with poor insertion techniques and management of insertion site. If throughout the procedure, we should maintain an aseptic technique like intravenous infusion, intravenous IV line insertion, like that we should maintain a aseptic technique throughout the procedure. Otherwise, it may cause inflammation and cellulitis formation on that area. Then patient may experience pain or discomfort at the insertion site. It is very rare. Usually the pain occurs when we are giving more than 20 drops in a minute. At that time, patient may experience pain. If the patient is having pain, just reduce the rate drops 22, then just reduce it to 20, 15 or something. Then wait for some times. If the patient is comfortable, then we can continue with the subcutaneous infusion. Still the patient is having, after reducing the drip rate, also patient is experiencing pain, then we should choose another site for the subcutaneous infusion. That is, we should resite the subcu-line. Then puncture of blood vessels during insertion. It is very rare in subcutaneous infusion because we know we are inserting it in the subcutaneous space. If there is any presence of blood in the scalp vein set, suddenly just remove the scalp vein and resite the subcutaneous device. Then there is a chance of hematoma around the insertion site. it is also very rare. It is associated with low platelet, or if the patient is receiving anticoagulant therapy, there is a chance of hematoma around the insertion site. So if we are starting subcutaneous fluid in the home care setting, we should go through the medical records if the patient is receiving any anticoagulant therapy or not. It is otherwise the patient, there is a chance of developing hematoma around the insertion site. It is very rare. If the patient is receiving anticoagulant therapy, there is a chance. Then infusion device occlusion. It is very, very rare in subcutaneous infusion. So likely cause is kinking to the external tubing. So after, if there is any occlusion showing, just check the external tubing. These are the some of the side effects and complications. Before starting subcutaneous infusion, you should explain these points. There is a chance of localized edema. When you are noticing a localized edema, you should give a gentle massage. And if we are not maintaining a strict aseptic technique throughout the procedure, there is a chance of inflammation and cellulitis. And if we are administering more than 20 drops per minute, there is chance of pain and discomfort at the insertion site. That time, just reduce the infusion rate and watch for the patient. If the pain is still persist, then look for another site. Then if we are inserting in the subcutaneous space, if there is any presence of blood in the tubings, that means it is not in the subcutaneous space. So just remove it and reside the subcutaneous site. And before starting infusion, subcutaneous infusion, we should check the patient is receiving any anticoagulant therapy, or if there is low platelet like that, we should. Otherwise, sometimes the patient may develop hematoma around the insertion site, and infusion device occlusion is very rare. Mainly it is caused by the kindling of external tubings. And nurse's responsibility. It is very important in nurses have so many responsibilities in subcutaneous infusion. And the picture shows this is the subcutaneous infusions. This is scalp vein. We should maintain like this, and the nurse should inspect the site every 4 hourly. 4 hourly for tenderness or hardness at the site. There is a generalized edema is there, but you should assess for any tenderness or hardness at the site, and check for any presence of any hematoma and leakage at the insertion site. Mainly the leakage is due to the increased administration of infusion rate. So you should check for the leakage at the insertion site. Local tissue irritation. So we know what are the medications we can give, and we are not giving through subcutaneously. The nurse should have a clear idea about that. We cannot give some oily preparation, most of the antibiotics we are not giving through subcutaneously. So if we are giving it, there is a chance of local tissue irritation. Then watch for any redness. Then is there any presence of blood in the tubing? We should watch, and displacement of cannula. We should watch for these things. So the nurse's responsibility include, we should assess the insertion site every 4th hourly for tenderness or hardness, presence of hematoma, leakage at the insertion site, local tissue irritation, erythema, presence of blood in the tubing, and displacement of the cannula. These are the main nurse's responsibilities in subcutaneous infusion. Okay, these all about the subcutaneous infusion. If any of you have any doubts, we can. Ma'am, the slides are over. If they have any doubts, we can discuss that.
Okay. Miss Anshu, isn't it painful? She's asking.
No, it's not distressing much as intravenous. There is a little bit of pain, little pain is there, but if we are introducing more than 20 drops over a minute, it will cause pain. So slow, we should give medicine as slowly as possible. It's not much painful, but for every needle prick, there is a pain. That's all.
If anyone having any doubts, you can put it in chat box. Otherwise, you can unmute and you can ask. We'll wait for a few minutes, ma'am. We'll wait for a few minutes.
Yeah, wait. The video purely show how we can give subcut fluids.
Yeah.
Like that, in our settings, some of the EOL patients are wished to spend their last time at home, their own home. That time, what we will do is we will teach the caregiver how to give subcutaneous infusion at home, and we can give palliative sedation with them. They will regularly came to our OPD and will refill the medicines. That's why how we are managing the end of life patients at home care. It is very useful, that type of patients.
Yes, ma'am.
And so many our patients are getting infusions at home cares also. Our team is doing this because it is very difficult to get IV line for these type of patients after
Yes.
getting chemo and radiotherapy. So it is very useful for that type of patient. The only one thing is we should well aware about the indications and contraindications about this. According to the patient convenience, we
How
can
many days we can keep?
we can 5 to 7 days we can keep the same line, but every fourth hourly we should check for that points. Is there any redness, leakage? That all we should assess. For maximum of 5 to 7 days we are keeping. If the patient is having severe pain or redness or anything, we should resite the site. Otherwise, it will develop into cellulitis.
So everyone is clear? Mikma, Renu, Neetu. You have any questions?
And one more thing is we can combine so many medications. We know in palliative sedation, we are combining morphine with haloperidol along with midas. Like that we can give. So in subcutaneous infusion, it is very easy. We can mix all these medicines and give it as
Can
one
keep by
syringe.
syringe pump.
Yeah, we can give.
So I think no one have doubts.
I think this is a simple procedure and everyone know about it. Yeah.
Thank you, ma'am. Thank you so much.
Thank you.
It is very useful for our students actually. And it is very useful in palliative setting, especially in end of life patients.
Yeah, mostly, yeah. Here in
Yes.
Pallium, most for end of life patients, we are most commonly using subcutaneous. We are not promoting intravenous infusions and all.
Here one question.
Yeah.
Same Anshu. Can we give medications in continuation?
Yeah, we can give morphine as continuous infusion. We can give fentanyl, haloperidol. Some patients are agitated at night, during night. That time we can start midazolam during night. Like that we can give any medicines. And I already said if the patient is having severe vomiting and all, we can convert the oral dose to subcu and we can give it as a continuous infusion.
Yeah. Thank you, ma'am. Thank you very much.
Okay, thank you. Thank you.
It's a good session. Okay, Hannah.
Yes. Yeah, thank you, ma'am. I'm sorry, ma'am, you are not audible.
Okay, thank you.
Thank you, ma'am. Thank you for your insightful session. And thank you, participants. So we can.
Okay, they have any doubts? Just free to contact me.
Yeah. Participants, please respond. Or else you can call someone's name and ask some questions. Then they will respond. Okay, they are saying thank you, ma'am.
Okay. Thank you.
Thank you, ma'am. So, dear participants, thank you. And we can wrap it for today. Today is the last date for submitting that assignment too. Please submit your assignments. Okay, so you can leave now. Thank you.